care outcomes. Now, prior to forming her company, Ms. Smilanic was with the Healthcare Distribution Management Association and headed the philanthropic HDMA Healthcare Foundation and also the National Association of Chain Drug Stores. Her BS in pharmacy is from the University of Minnesota and her MBA from the University of Maryland. She completed the American Society of Health System Pharmacy executive residency and has an associated management as well. She's a practicing pharmacist and pharmacist immunizer working with both independent and chain pharmacies. Ms. Smilanic is also an associate fellow at the University of Minnesota College of Pharmacy Center for Leading Healthcare Chains. Now, before we get started, I want to let you know that Ms. Marsha Smilanic has no actual or potential conflicts of interest in relation to this CPE activity, and this program shall exhibit fair content balance, providing the audience with information of different perspectives from which to develop an informed professional opinion. And now, Ms. Smilanic.
Thank you, Renee. I am very delighted that we have such a huge number of people turning out tonight for such an important topic. We've got a number of learning objectives that will cover both the pharmacist and the pharmacy technician, since together they're the core team that make up the base of the community pharmacy practice. I certainly know that from my experience in the community pharmacy environment as well. So what we want to do is look at the rate of occurrence of medication errors and the related healthcare and societal burdens. We really want to be able to recognize and list commonly occurring medication errors. We want to talk a little bit about the role of risk assessment in reducing medication error rates and how that can improve patient safety. And then we also want to talk about preparing available risk assessment tools that the pharmacy team can actually use within their setting in order to determine if there are some steps they can take to reduce errors. With our pharmacy technician team, which is the next slide, okay, and so with our pharmacy technician team members who are on the webinar tonight, we want them to be able to also formulate some action steps that they can take to implement risk reduction in the pharmacy. So we've got some extra things we're going to do with our pharmacy technician audience. When you think about dispensing errors, you know, I know most of us think, oh, we don't make many or we can't, but boy, you just look at the very numbers. If the average pharmacy team, that's the pharmacist and the technician, fills or reviews about 250 medication orders or prescriptions each day, that means in an average week that we work, we are actually looking at about 1,250 prescriptions or 60,000 in a year, and if you work full-time, that's about 1.76 million prescriptions that we as a team touch in our lifetime as pharmacists and technicians. And I guess I would just pose to our audience, you know, what do you think the likelihood is that you will make a medication error during the course of your career? How likely do you think it is, given the sheer volume of medication that we are in charge of processing in a week or annually? And I would submit to you that I think all of us have the potential to do that. And in fact, when studies were done within the last decade looking at dispensing errors, Elizabeth Flynn found that about 98.3% of the time there's accuracy in dispensing medications, but that means that 1.7% of the time there may be issues. And if you look at the fact that there are over 3 billion medications dispensed in the U.S. each year, that means there are 4 errors per day per 250 prescriptions filled. So again, in an average shift in our pharmacies, if that was our prescription volume, we probably make 4 errors a day, or that equates to about 51 million errors in a year. And the impact is substantial. A study was done in the early 2000s by the Institute of Medicine. You may remember it. It's called To Err is Human. And they documented more than 1.5 million preventable medication-related errors that occur each year. And in fact, the fact that adverse drug errors were the 4th leading cause of death in the United States. They actually they cause more deaths than car accidents. So there really is an opportunity for the pharmacy team here to enhance drug therapy management, risk assessment, and analysis, and make sure that we can offer a safer system as we go back to practice, even as soon as tomorrow. So what is a medication error? Well, the National Coordinating Council for Medication Error Reporting and Prevention defines it as any preventable event that can cause or lead to inappropriate medication use or patient harm. And obviously, when you think about the breadth of the dispensing system and the prescribing system, errors can occur in a number of places, which we'll discuss a little bit later. Now, an adverse event can also be defined as an injury caused by medical management rather than the underlying condition of the patient. An adverse event that's attributable to an error is called a preventable adverse event. Now, there's a subset of those called negligent adverse events that satisfy the legal criteria used in determining negligence. In other words, there are some errors that we make that perhaps are not negligible or put us at liability for being sued by a patient, but there are others that we might be able to correct. An error in and of itself is just a failure of a planned action to be completed as intended. So that is the difference between an adverse event and an error. And when we look at the cost of these, it's actually been predicted in that same report to be $37 to $50 billion, and that includes the lost income, lost household productivity, any disability and related health care costs. Now, preventable adverse drug events cost about 17 to 29 billion of that. About half of that goes to related health care. They're about 1% of all health care costs, whereas errors are about 2% of all health care costs. So I'd like to take a pause here and let's poll the audience, see how well we've started out with our listening. So which of the following statements about medication errors is false? 1, there is more than 98% accuracy in dispensing medications. 2, estimates are there are about 4 errors per day per 250 prescriptions filled. Or 3, over 75 million dispensing errors occur each year. So go ahead and let's weigh in on that.
Okay, Ms. Malonic, we have almost all that have voted, and we have 62% for C.
Fantastic. Well, that's really good listening. That is correct. That is the wrong answer because it's actually over 51 million dispensing errors occur each year. So number 3 is the false answer. Number 1 is correct. If you remember, Elizabeth Flynn documented a 98.3% accuracy in dispensing medication. And again, the estimates are that there are 4 errors whenever about 250 prescriptions are dispensed. All right, so let's change our attention to some of the things where we can really make a difference. Now that we know that errors are a problem just by the sheer volume of prescriptions that we touch as a team, what are some of the causes, the common causes of adverse events? Well, first, I think it's important to point out people don't make mistakes on purpose. You know, Sidney Dekker has made a career out of studying human behavior and error management, and what he has said is that what's so striking about so many accidents is that people are doing exactly the sorts of things they would usually be doing, that the things that usually lead to success and safety. You know, seldom are accidents preceded by bizarre behavior. In fact, it's just really the fact that we're all trying to do the right thing, but accidents can happen anyway. Now, the Institute for Safe Medication Practices is a nonprofit organization that is dedicated to studying and creating tools to help pharmacists and pharmacy technicians in all practice settings address the medication safety issue. ISMP estimates that the medication process consists of about 40 steps. That's a lot when you think about all the little pieces of processing and safely dispensing a prescription and educating a patient. 40 steps, and a breakdown in any one of the steps has the potential to cause an error. They've been able to document through a study, the Bates, done by Bates and Cullen et al., where these errors occur, and fully 56% occur during prescribing, 34% occur during administration of medication, 6% occur during transcription of orders, while 4% occur during dispensing. Now, we can also look at different ways errors occur. A root cause is the most fundamental reason an event has occurred, and we're going to come back to that later when we talk about risk assessment. Contributing factors are additional reasons that the error occurred, not necessarily the most basic reason that an event occurred. And it's important, later we're going to talk about sentinel events. And a sentinel event is an unexpected occurrence that involves death or serious physical or psychological injury or risk. And how we may do a risk assessment will vary by whether it's a sentinel event or not, and we're going to talk about that later. So I bet you could probably guess what some of the most prevalent dispensing errors are. And I know I have made certainly one or two in the course of the last 10 years that I've been practicing here. And these are the errors that have been made. Incorrect medication, or the wrong strength, or the wrong dosage form. We can often miscalculate dosages with oral antibiotics, perhaps, or if we're compounding medication. Or maybe we have failed to identify drug interactions or contraindications. And there's some important pieces of that pharmacy technicians can help us with, and I'm going to enjoy talking with to that point a little later. So there are several types of dispensing errors. This is a slide that categorizes them. There are errors of commission, which is dispensing the wrong medication or a miscalculation of a dose. There's errors of omission, which is a failure to screen for interactions or contraindications, or even a failure to counsel. There can be mechanical or judgmental errors. A mechanical error usually happens during the prep and processing of a prescription. A judgment error, on the other hand, tends to involve patient counseling, screening, or monitoring. We often can make mistakes just because we lack the knowledge otherwise. Slips can often happen due to poor workflow design, or maybe we're distracted. Not that I think any of you ever get distracted at your practice site. There's also potential and actual dispensing errors. Potential errors are those that we detect and correct prior to the administration of a medication, while actual errors are those that unfortunately do reach the patient. Let's talk about some other causes. Other common causes, if we use outdated or incorrect references. I know that many community pharmacies have different policies and procedures, and they may limit whether or not you can bring in your cell phone. And as you know, today our smartphones are often a source of great drug information. I know I keep drug information on my phone, but the firms that I practice with don't want those in the pharmacy. So I know I need to rely on the references that we have and trust that our corporate environment is keeping them up to date. Other pharmacies may not be so. So again, you want to be sure those references are updated. We can also look at our external environment. I mean, the workload can be disrupted. There can be distractions in workspace. I know the particular pharmacy where I work at has a very loud music system, and I have to constantly turn the volume up on the phone when I'm trying to transcribe prescriptions from people. So I just don't hear that well anymore, and that can be a real distraction to me. There's also drugs-related or errors, related to drug information or patient information. We talked about the references. There's often ambiguity in handwritten and typed prescriptions, and something that obviously with e-prescribing has been helpful, although it certainly takes a while for those systems to get in check, and we can often see some discrepancies between what we have and what comes in through new e-prescriptions as well. Wrong patient errors and errors in dosage. So these are extremely common reasons for dispensing errors. We can also have mathematical errors and decimal point misplacement, and I'm going to talk about that later, and often even conversions between micrograms and milligrams. Oral liquid medications can be dispensed wrong because we may have misunderstandings with syringes or devices that are used by parents or pediatric patients. And I just wanted to provide an example. I can't imagine that any of you don't see this every day in your practice, but I look at these, and the first one, Amaryl, I can't quite tell if that's 12 milligrams PO every day or every 6 hours or 2 or what it is, and same with the Digoxin, 0.125 is that every day. Such a dangerous medication, I would hate to guess that. And the same with the Dilantin and the Tegretol below. You can't tell which one of those is supposed to be taken twice a day. It's really quite confusing, and we hate to just make assumptions that can lead to an error. Now, we can often avoid some of these issues by taking these steps. If you know local terminology, you can write neatly, and don't use trailing or leading zeros. I've given you a couple of examples here. So write 1 milligram, not 1.0. Write 0.1, not 0.1. And these are things that can help reduce errors. All right, so I want to stop, and let's do our second self-assessment question. So common dispensing errors include which of the following? 1, failure to counsel the patient. 2, failure to screen for interactions and contraindications. 3, dispensing incorrect medication, dosage strength, or dosage form. Or 4, all of the above. What do you think? Go ahead and weigh in on that.
Oh, Miss Malonic, we have a quick group here tonight. We have 92% for D, all of the above.
Very good. You are listening incredibly well. You are right. All of those are common dispensing errors. So, again, I really appreciate your sticking with us tonight and paying good attention. So that's great. So let's move on to our next slide. All right. So let's talk a little bit about reducing medication errors. I mentioned that there was a report in 2000 called To Err is Human, and that really has brought on a flurry of attention, research, adoption of tools, and voluntary reporting because of that report, and I think that's what's so important. I know some states even require pharmacy technicians to do mandatory patient safety education as a result. But the IOM really did establish that national focus that's led to a lot of energy and effort in the last decade or 15 years on errors. Next slide, please. All right, and so if we look at what the Institute for Safe Medication Practices has documented, they have, again, done a lot of research showing what are the elements in the medication use system. And there are 10 core elements in the medication use system. And if you understand these elements, this is where the team members can take various actions to reduce the potential for error. And we will walk through each of these, but these are patient information, drug information, communicating that information to the patient, how a drug is labeled, packaged, or what its name is, how it's stored, stocked, or distributed, the drug, device, acquisition, use, and monitoring, environmental factors, staff competency and education, patient education, and again, quality review and risk management. We're going to talk a little bit about that. Now, studies have been done by the World Health Organization, and the people who are most at risk for medication errors are those on multiple medications, those with comorbid conditions, those with low literacy or communication skills. Multiple prescribers often present that issue, as many of you know. children and infants, often because of dosage requirements. Now, other things that we need to look at when we look at reducing risk for errors is making sure that we have adequate staffing levels. And the ISMP recommends eliminating dispensing time limits or quotas, and they provide some examples of limiting workload. Now, I appreciate the fact that many of us don't have the opportunity to control this in our environment. So I think it's important, if we don't have meal breaks or we can't control the number of people that we're working with on a particular day, that if we're starting to get tired, you really just need to take a step back. Take a quick, just walk away for a minute and get an energy bar, do something to break that kind of habitual process and make sure that you're doing okay within the constraints of your work environment. Again, minimizing distractions, I think, is really important. And as I mentioned, I tend to turn up the volume on the phone. I think some of the newer medication synchronization programs have really helped to ease workflow and provide more opportunity to do patient education, as well as centralized filling operations have helped in that as well. So that can be useful. Reducing clutter, I think, is really important. I think most of you probably have workflow processing. Some people may use prescription baskets or what have you, and the stock product moves through there. But making sure that there isn't a lot of stock products sitting in front of you while you're dispensing can really help. Any kind of poor ergonomics that get in the way, making sure there's adequate light and comfortable environment, as well as labels on bins and shelves, I think is really important. Using high-intensity task lights and magnification, being able to hold prescriptions at eye level. I know where I practice, one of the funnest things we found was there is a very pliable earwax that's just slightly sticky, and you use a dab of that in front of your computer screen, and if you happen to have a paper prescription, it'll stick right there, and it puts it right at your eye level so you can see what you're doing much more easily. So a lot of fun workarounds we found in our pharmacy team. All right, drug storage. I think this is really critical. I think most of us rely on our pharmacy technician team members, but we need to have adequate space to store the medication and make sure that the labels are facing forward. Often separating the drugs by route of administration can help reduce errors. And marking and isolating high alert drugs. One suggestion has been to put Post-it notes on look-alike and sound-alike drugs just to alert the team member who's pulling a drug from the shelf. And I think that's really critical. That's been proven to reduce errors. And when you think about it, think about a lot of the look-alike and sound-alike drugs, and these drugs are used for very, very different things. I've given you some examples here. And what's great is the Institute for Safe Medication Practices actually has a terrific listing of these, and I've provided you with the website where you can go in order to print this out. I really encourage you to print this out, bring it into the pharmacy, and this can be a great technician, pharmacist team exercise on a weekend when things are slow to look at those and try to separate them. Labeling and packaging is really critical, even in your liquid section. You know, if you're stocking products by the same manufacturer, look at how closely these labels resemble one another. Even though they may be alphabetical on a shelf, it's really important to separate these products so that we don't accidentally pull the wrong one off the shelf. There are an awful lot of dispensing errors that are caused by poor patient education, and I think this is really a critical area. The pharmacist technician at the out window can be key in helping the patient access the pharmacist, making sure questions are answered, and getting the pharmacist to understand if the patient, again, has any questions. I think it's really important. In fact, one study found that up to 83% of the dispensing errors could be corrected during patient counseling and before the patient left the pharmacy, if time was just taken to do that. So again, 83% by doing appropriate look and counseling. Now, one of the other key things here is prescriber recommendations versus what patients have selected, and I think it's an important opportunity, again, for the pharmacy technician to bring the patient to the pharmacist in a case like this if they come to the counter asking, you know, where's the Ducalax tablet? And these are 2 Ducalax tablets, but they have very different ingredients for different uses. So I think this is really critical when our pharmacist technician team members can come help us do the right thing with patients. We may not realize they have questions. All right, and making sure that patients know the name of the drug, why they're taking it, what they're supposed to be taking, and what side effects may occur, and what to do about that. And if you do happen to have any references that you could suggest for the patients, I know lately I've been frustrated so many times it seems the patients say, I don't want that information, I know everything. But I think it is important, at least initially, to make sure we understand that they know what they're, that they're knowledgeable about what they're taking and that we can listen to them say it and provide follow-up if needed. All right, we really want to, again, encourage patients to be active in that process, and one of the ways is to encourage them to keep a written record. If you are all doing medication therapy management at all, one of the key things here is providing patients with a personal medication record, and I think that's really important for a patient to have that and to present it to you and their physician. It may not be ideal to have it in writing, but I think most patients do tend to carry it that way. Again, double check. Really emphasize to those patients, know what you're taking, ask us if you have any questions, use the same pharmacy, and I think this, again, is key where we as a pharmacist, pharmacy technician team can really provide some excellent patient service, and hopefully they'll come back to see us more often when we do that. The pharmacy systems themselves can also be designed to help prevent dispensing errors, but, you know, I'll say garbage in, garbage out. You know, at the intake window, often I find that maybe we're not doing 100% of the time asking patients if they have any allergic reactions or cross-sensitivities. And that's really important because we may, if we don't have allergies in the system, no matter how good the system is, we're not going to find out that there's a contraindicated drug. So, again, I know I rely on my pharmacy technician teammates to really put that in the system. I'm really grateful, too, where I practice that our centralized IT department does a wonderful job of upgrading our computer system, which is terrific. And if you have control over that, I think it's really important that you work with your vendor to know how often they update the system. In addition, I think the pharmacy team really can think through and figure out new ways to educate patients and caregivers about medications they're taking. We talked about the importance of giving patients a personal medication profile, and again, always encouraging them to double check a medicine. And I know we use auxiliary stickers. I imagine many of you do too. When we change generic source of supply, we want to alert the patient, hey, this is the same medication, but it's going to look different, and it may, but it is the same drug at the same time. So I think that's important. The theme for Know Your Medicine, Know Your Pharmacist is part of American Pharmacist Month, which happens in October of every year. And I think that's a wonderful time to focus some interesting promotional efforts around medication safety, patient profiles, getting personal medication records out, and that type of thing. So I'd encourage you to think about that. Since it's only January, you have 9 months to plan ahead. Now, there are also some steps that can be taken with regard to the double checking. You know, if we want to try to do independent double checks before medications are dispensed, so pharmacists are checking tech work, and some of this is clearly now written in legal statutes and your state regulations, but sometimes we find ourselves working alone. I know I certainly don't like it, but it does happen, and when you're by yourself, you know, how do you double check yourself? So I think it's really important. There are some tips here. If you are working alone and you don't have your pharmacy technician teammate there, you know, switching hands when you're rereading the label or delaying self-checking from the time you filled it so that you're not just creating the assumption you had when you input the prescription, processed it, dispensed it, and QA'd it. And then trying to see if maybe recalculating any calculations using a different process, so that's important. Other manual redundancies, again, with compounded products, they should be checked before dispensing, and there are many new recommendations in the USP 795 chapter on non-sterilized compounding standards, so I encourage you to look at that. In addition, when we assess a prescription, making sure we clarify anything we don't understand or any non-standard abbreviation. I think we've seen, again, much of this as we've gone from manual to e-prescribing systems. When they're first implemented, there can be a lot of discrepancy between what has been happening and what's coming in. Looking at that profile, reviewing the interactions against an updated allergy profile, and verifying appropriateness of it is really key. Now, ISMP has provided 10 steps to maximize dispensing accuracy. Their top 10 are to lock up or sequester drugs that could cause disastrous errors, so really dangerous drugs, developing and implementing procedures for drug storage, reducing distractions, designing a safe dispensing environment with great workflow, using those reminders on labels, especially in look-alike and sound-alike drugs, keeping original prescription orders, labels, and containers together through the process. Again, if you're using, the tray method, I think that can help. All right. And continuing then, comparing that content of that medication container with the information on the prescription, and many new barcode systems are in place that can assist us in this process. Entering the drug's ID code into the computer and on the label, and again, many barcode workflow systems now automatically do that. And that's also true during that final check on the prescription when we can scan that in. But it isn't 100% foolproof, and that's really important. And again, providing patient counseling, because as I said earlier, fully 83% of dispensing errors can be caught and corrected before they ever leave the pharmacy, which is key. All right, so there are a number of risk assessment tools, and I would submit, what it is and why do we need it? Well, the whole goal of risk assessment, when errors are made and people come back and try to find out why, it's often a systemic issue. And I will go back to the beginning, Sidney Dekker, we don't make these errors on purpose. There are reasons why these errors occur, and if we can look at the reasons why the errors occur, then we can take steps to prevent them. So that's the goal of doing any kind of risk assessment. It helps us understand what are the parts of safe pharmacy systems. It can help us create a baseline in our pharmacy. Where are we at today? And if we actually do these risk assessments, a year from now, can we look back and see if we have made fewer errors in the pharmacy? So it's really a quality improvement opportunity that I would encourage you to take. So there are several tools, and these are, again, available at the Institute for Safe Medication Practices website. They have just a tremendous 20-year history now of studying errors and pulling together tools, especially in the community pharmacy environment. There are a couple of them I want to highlight here. The HAMMERS tool, which stands for High Alert Medication Modeling and Error Reduction Scorecard. And then there are two other detailed tools. There's a Medication Safety Self-Assessment, or the Assess Error tool. And then there's a root cause analysis workbook that was funded by the National Association of Boards of Pharmacy as well as the Community Pharmacy Foundation, and has recently become available through IMSP. So let's talk about HAMMERS first. HAMMERS, if you're a really busy pharmacy, this may be a really quick way to start because it's a scorecard system. It's a free tool that is meant to be used in the community pharmacy by the pharmacist and pharmacy technician team that helps identify any unique set of system and behavioral risks when you dispense high-risk medications. So the goal here is it's a scorecard system that you can do in your pharmacy that targets high-risk medication. So it assesses 5 categories of pharmacy error. It looks for the risk factors in the process you use in your pharmacy, and then it provides you with a risk impact. So it's something, if the scorecard shows you're at risk, it'll tell you the level of risk. And by using this, the pharmacy team can estimate how often errors might reach patients and how the frequency will change if certain interventions are made. So again, I really encourage you to get that HAMMERS tool. It'd be a fun thing to do on a slow Sunday at the pharmacy and see what you can do. The other opportunities, as I said, there's 2 other tools that the ISMP has put together. One helps the pharmacy do a root cause analysis in the event of a very serious error. The other is a starting point for success successful organizational improvements. So again, it allows you to know where you're at risk and you can put things in place. So let's walk through what those are. So the first one is the Assess Error tool. This one is a 3-step worksheet that helps the pharmacist and the pharmacy team with error report investigations. So if an error has occurred, this is a process you could go through to identify what system issues existed that led to the error, and that way it can be corrected. And that could be, the wrong med was pulled off the shelf because it was next to one that it looked like. So in that case, you're going to change the way the medication is stored. So the idea here is let's convert a negative experience into a positive one. It's very standardized, so regardless of the error or the people involved, you're going to use the same set of questions to identify these system deficiencies. And the thing I really like about it is it ties back to those 10 areas of the medication use process that have been identified earlier. And I've given you the web reference for this particular tool. I think it's key. Now, the newest tool that's available is this root cause analysis. And again, this one is a much more in-depth, systematic process that identifies the causative factors that occurred in a sentinel event. And I want you to take a minute. Can you go back to the beginning? What was a sentinel event? Is a sentinel event when you just put, a green generic that's the same as the old white generic? No, obviously not. That's not it. A sentinel event is one that causes significant injury or harm or death. So this is a really bad one. And when that happens, you want to be able to do this root cause analysis. And I've given you a picture of what it looks like. So again, the root cause analysis, sentinel events, it focuses on systems and processes, not individual performance. It continually asks why until all the root causes have been identified. Typically, 5 rounds of why did this occur are needed to be identified before the root cause is found. So it's really an important team-based tool. The other thing they recommend is it's a team of people that's formed, including some of the leadership and some of the staff. So it's a leadership and a team. It's very internally consistent, and it considers all of the relevant literature on dispensing errors. So I think this is a really great tool. So the basic questions of a root cause analysis are, what happened, what normally happens, what do policies and procedures in our pharmacy require, why did it happen, and how were we at the pharmacy managing the risk before the event. And so as you delve into this, it's going to allow you to develop, again, strategies you can put into play, whether it has to do with drug storage, whether it has to do with patient education, whether it has to do with look-alike or sound-alike drugs. So whatever the issue, this workbook is going to help you deal with a sentinel event. And again, I'm going to go back to the other tool I mentioned. The Assess Error tool is one that you can put into place for any other medication error that occurs. Now, I know in my particular pharmacy where I practice, we have our own tool that we use when we find an error, and your company may have a specific policy and procedure and form that they use. But if they don't, I think the Assess Error tool is a really good one to start with, and it certainly wouldn't hurt to look at that tool compared to your company's tool and see if some improvements can be made. Now, errors should be reported. The Institute for Safe Medication Practices operates the National Medication Error Reporting Program, or the ISMP-MERP. And at their website, you can see you can report a medication error. So this is voluntary, and it is not traced back to you. It's anonymous. And the purpose of this is it's building the database from which ISMP and their staff and committees actually create tools to help reduce risk. So it's really important to make error reporting part of your normal process. Now, I also mentioned that ISMP has been in the business of patient safety for well over a decade, possibly 2. And I think that there are numerous resources that they have that can help you identify where you can improve patient safety in your pharmacy. And I've given you the web address here, and I'd encourage you to start there. In addition to the Institute for Safe Medication Practices, there are a number of other organizations that look at patient safety, including the National Patient Safety Foundation, Pharmacy Quality Commitment, the University of Washington Center for Health Sciences Interprofessional Education, the Joint Commission for Accreditation of Healthcare Organizations, that's for many of our colleagues in institutional and ambulatory care, and of course the National Coordinating Council for Medication, Error, and Prevention. So those are some of the resources. And we can certainly get into what happens, how you should handle a medication error as well, but I think we've addressed the objectives that we set out to, and we have plenty of time for questions. So I'm going to go ahead and let's see if we can answer some of your questions.